Good afternoon. Thank you so much for joining us. I'm sure folks are signing in, so we'll give folks just a minute or two here before we get started. It's a pleasure to have everyone with us for our second annual Inclusive Excellence Week here at the School of Dentistry at VCU School of Dentistry. I am Carlos Smith, our Director of Diversity, Equity, and Inclusion, as well as our Director of Ethics Curriculum. I'm an Associate Professor in the Dental Public Health and Policy Department, and I'll be the speaker today to kick us off. We have a great week of events lined up every day at lunch, 12:15 to 1:15 Eastern Standard Time. So please join us for this week's events. And we'll actually go ahead and get started. If you have questions at all, you can jump into the chat or the Q&A feature as well. All right, so let's get started. All right, so just a brief touch on our learning objectives today. We're really talking about, which I think is obvious from the title, the history of understanding racism in healthcare, giving a lens of ethics and professionalism. And that is going to provide us a rich opportunity in terms of advancing health equity. Briefly, our objectives are to describe the history of racism in healthcare, explain correlations between historic practices of racism and discrimination to present-day health disparities and inequities. We'll articulate a history of medical mistrust, particularly within vulnerable communities, and also describe opportunities for racial healing. And then we'll explain how historic and modern focus on ethics, professionalism, and interprofessionalism can actually advance health equity among our most vulnerable populations and communities. So I really like to start my presentations because we're forever learning, right? I haven't always done this, but in the last year or so, whenever I give a presentation, I always like to start with an indigenous land acknowledgement. For many reasons, really, certainly in the spirit of inclusion, right? You want to actually include and be inclusive in what you're doing. But I think it's also important that we acknowledge that before any of us were a twinkle in our mother or father's eye, there was this land that was here, right? Particularly when we think about history of the United States and colonialism and conquest and empire, which is really a global thing, not just specific to the US. But with the US, you had indigenous populations, particularly the population that occupied VCU, were the Powhatan people, right? They were the indigenous Algonquian people in our area. I'm really impressed with Northwestern in Chicago. Their university really talks about and gives some history of why indigenous land acknowledgements are important. And then if you go to that nativeland.ca web address that you see on the screen, you can actually even put in like your home address, your work address, where your practice is, maybe your home of origin where you grew up, and you can see the indigenous group that originally occupied that land. And I think it's really neat, and I think it's just, I'm a history buff, which anyone that knows me knows. So I think it's a really neat exercise, particularly as we think about health disparities and where that shows up really for our Native folks as well, right? If you know anything about me, you know that everything we do, particularly in our diversity, equity, and inclusion initiatives, are going to be grounded in ethics, right? So what are ethics, right? Ethics is really the understanding of our choices, what we choose to do, what we choose not to do, what we choose to do, and the act of actually not acting, right? So if you don't act, that's actually an action. And so ethics really grounds us, particularly as healthcare professionals, when we start wading into waters that are sometimes deemed controversial, such as racism or the history of racism. I think it's important that we have an ethical obligation as providers, as members of a healthcare team, as those who work in a healthcare facility, as those who maybe are front desk folks, those who are training future health professionals, in our instance, oral health professionals. It really is an incumbent upon us to think about and keep at our forefront this social contract we have with our population, this social contract that we have with folks we're supposed to serve and have taken oaths to serve and been licensed to serve, right? So our ethics really should guide us in all that we do and all that we see and all that we understand, even for those subject matter areas where we're feeling uncomfortable or not maybe well equipped. Our ethics should guide us to say, okay, why don't we have some thoughtful inquiry around this topic, whatever that topic may be, particularly when you're talking about racism. So I think it's important to note that many of our organizations across the healthcare landscape, when you look at the American Public Health Association, the American Medical Association, even the American Association of Public Health Dentistry, the CDC, many of our organizations have been very clear in delineating that racism in and of itself is a public health crisis, right? And so for some that may stem controversial, I think it's important that we depoliticize this issue, right? So I think sometimes people are saying, oh my goodness, is this all connecting to cancel culture? Is this all about being woke? And those sorts of things. We're not talking about any of that. We're talking about actual issues that connect and correlate to either the impediment of or the improvement of oral health outcomes in our advantage, right, as oral health care professionals. So we're really connecting the dots to all of these issues to improve outcomes for patients. Now, there is a moral argument that one could make, certainly, and that I make as an ethicist. There's an ethical argument, which we just heard just a little bit of, but it's not to be politicized. It's not about having a political agenda or right wing or left wing or anything of that nature. This is actual studied. There's research that I'm going to put forth around racism as a public health crisis. And so what is racism, right? I'm someone who really likes words. I really like definitions so that we're all on the same page. So racism structures opportunity and assigns value based on how a person looks, right? So the result are that we have conditions that unfairly advantage some and unfairly disadvantage others. So racism hurts the health of our nation by preventing some people the opportunity to attain their highest level of health based solely on the race from which they present, I think it's important to be clear that this can be intentional, but also unintentional, right? And it operates at various levels across society and is really a driving force of social determinants of health, which we'll look at a little bit later, and is a clear barrier to health equity. So now the social determinants of health, with I hope most of you are familiar with, but what it really looks at is outside of simply being healthy or like actual health measures, like do you have decay, right, in your mouth? Do you have periodontal disease? There are all these other factors that determine or have an effect on how someone either receives healthcare, so delivery of healthcare services, or how healthy they just are based on these, what we call social determinants of health. So what we're looking at here in this framework, if you will, is access to healthy food, right? Neighborhood safety, housing stability, income level, education quality, and even transportation availability. So all of these things affect very clearly if someone receives healthcare delivery or if they're able to reach their optimal level of health. Let's make that very clear in a dental scenario or example, right? So many of you may or may not be familiar with Medicaid. Medicaid is a system that is income contingent. So there is a litmus test, if you will, around income, around access to finances of wages earned. And so for lower income folks that are able to qualify and receive Medicaid, we have a new expanded dental benefit right in the state of Virginia. I've practiced in 2 states, Virginia and North Carolina. North Carolina has had expanded dental for a good while. But what makes the difference, and if that person, even if they have Medicaid, so they have public insurance that pays for their care, what makes a difference if that person actually receives the care or not? All of these things within social determinants of health. It also makes a difference if they actually can find a provider who accepts the Medicaid. So many of us, those of you that are in private practice, may not take Medicaid, right? And I've been in practices that took Medicaid, and I've been in practices that didn't take Medicaid in terms of a practitioner profile. So I have experience with both. And a lot of times there are stigma, stereotypes. You don't want that element in your office. You don't want to feel like a clinic. All of these things are hindrances to folks that have that public insurance being able to capitalize on those services, in addition to all the things we see here. So let's take one of those stereotypes, for example, that Medicaid patients don't show for their appointments, or they're late for their appointments. Well, has anyone ever stopped to ask, why are they not showing for the appointment? Why are they late for the appointment? So then we began to look at this framework around transportation access, right? So do they have to take public transportation to get to that office? How many bus transfers does it take? What is the cost of that public transportation? Are they weighing out different things like, I either miss my hourly wage that I work from a job to keep this recall appointment that, you know, we deem important, but they may not deem important because they're not in pain. So you're looking at also weighing out decisions of, do I make my Medicaid copay or miss the opportunity to earn my wage so that I can go to this appointment? Am I having to manage and decide, okay, do I put food on the table today? Am I able to buy my lunch today? Am I looking at deciding between a heat bill or some type of utility bill, water, grocery, and dental care? So there are a lot of things that go into the factors of social determinants of health. One of the things that we're talking about now that's in the scholarship is that racism in and of itself is also a social determinant of health. It in of itself is a determinant of health, right? So a 2015 review of hundreds of studies that were looked at between 1983 and 2013. So you're talking about over many decades there, right? Confirmed that racism is consistently associated with increased mental health conditions like depression, anxiety, and psychological stress. It also shows evidence that racism contributes to poor physical health outcomes. So racism plays a fundamental role in the social determinants of health that medical research links with worsening health outcomes among varying populations. So I think this is an important factor because we talk about structural or systemic racism, right? And before you exit and go off into some political place, think about just the definitions again, not how it's slanted or being used for political fodder, but what does it mean to be structural or institutional versus personal? What does it mean to be systemic or institutional versus personal? Sometimes folks will say to me, Dr. Smith or Carlos, I think racism is a personal issue. There's no way it's institutionalized. Okay, so let's take that supposed truth, if you will, or opinion, if racism is a personal decision. Well, how are systemic decisions made? How do decisions become institutionalized? How do policies become institutionalized? By people, right? People that are on committees, people that are CEOs or in positions of privilege and power or of influence, people that are on educational boards, people that are on the board of dentistry, people that comprise our societies in terms of professional organizations and professionalized dentistry, organizational dentistry, are people. And so those people can be influenced in the racism that they potentially harbor or the bias they potentially harbor can then influence the policies and procedures and practices of institutions. This iceberg is from a study from 2007 that talks about the racism iceberg in terms of what we see above the water and what we see below the water. So above the water, what's obvious to most folks is hate crimes, microaggressions, what we'll talk about a little bit later, and everyday slights. But what's undergirding it? What's feeding it? Why do the patterns continue to happen by race? What causes the racial patterns to be maintained across time and place? Are those things underneath? Mass media portrayals, mass incarceration, political representation, occupational, residential, school segregation, and even mortgage redlining. Which leads me to this. Do you realize that in the United States, purportedly one of the most prosperous countries in the land, right? That one's health is most greatly predicted by your zip code. Not your medical history, not your blood pressure, not your cholesterol, not even genetics per se. One's zip code is the greatest predictor of life expectancy in the United States. And so this is a really good text if you want some follow-up work to do around the color of law, a forgotten history of how government segregated America. And it talks about this concept of redlining. And here you have this image that shows Del Mar Boulevard, right? And so on one side of that boulevard, and this could be any city, this could be Richmond, this could be Broad Street, right? Where you have north of an area as not favored, and so the home values are lower. they're typically a greater concentration of African Americans historically, versus the South side of something may look very different, and it's separated literally by what's called a red line, right? A line that banks and institutions use to determine where mortgages would be okay. And this is holistic and systemic in many ways, because this is connected to like the GI Bill. So when folks came back from World War II, you had white soldiers who came back and were able to take advantage of the GI Bill and get mortgages. And you had Black soldiers who came back and were not able to capitalize on their service to our nation, right? And their being real patriots in war, right? Even though they're Black, and sometimes that is a counter narrative, but that is a true narrative that exists, that you have Black folks who are patriots, right? And so they weren't able to capitalize on the GI Bill, whether that was through banking, educational access, and a litany of things. So all of this plays into a history of racism, and it's gonna connect to our healthcare outcomes. So this is something I like to posit for people, right? And this may be a little tough for you, but think about Nazi Germany for a second, right? So these are images from the trains in Nazi Germany. And you have slight images there of the folks who were the train station managers. They were public servants of Nazi Germany, right? Public servants of Germany, train station managers. They were not making policy. They were not in leadership of Hitler's regime. Public servants, as it were. Their job was to keep the trains running on time. Now, we ultimately know the destination, unfortunately, of those trains were to the demise of so many of our Jewish brothers and sisters, right, during the Holocaust. But their goal, their mission, their job, their performance evaluation was simply, do I keep the trains running on time or not? Now, the question I have for you, are those train station managers, were those train station managers doing something evil? They're just doing their job to keep the trains running on time. They're not wading into politics. They're not wading into controversial waters, right? They're not wading into political waters, as it were. They're train station managers, public servants. But are they doing something evil, even in this public service? A quote from that paper: ordinary people within their normal professional and administrative roles, right? So think about what you do every day as a profession, what you do every day as your job, what your colleagues do every day as their professional or administrative activity. Ordinary people within their normal professional and administrative roles can engage in acts of evil without being aware that they are doing anything wrong, and those same people may even view their evil activity as good. So I posit for you again, it's rhetorical in a sense, but not, were the train station managers participating in evil? So I think what we have to recognize here is that at times we can be participants in a system, right? In an institutionalized system that disadvantages some and advantages others simply by the color of their skin. So think of all the isms, simply by their sexual orientation, simply by their gender identity, simply by their ethnicity. So are they Hispanic or Latinx? Simply by their immigration status, simply by whatever you would like to fill in the blank, disability, right? So I think it's important when we think about these issues around diversity, equity, and inclusion, that we also think about what's visible to us, but also what's invisible. So often we forget to talk about disabilities or those who are not as able-bodied, right? And so that's important for us to think about. How may we participate in institutional systems that are disadvantaging and advantaging others simply by one of the identities that they check? Let's look specifically too at a historical and contemporary lens when we talk about related healthcare experiences. Now, this specifically is talking about the African-American experience within the US, but I want to shape this very clearly for you in terms of time frame. I also want to just offer, particularly for those of us, again, in the healthcare vantage, you'll hear rebuttals to what I'm saying, like, well, why do we stay stuck in history? Let's move forward. Why are we still talking about this? What's the first thing we do with any patient? The very first thing, besides an introduction, I hope, you take a medical history. We take a health history, and we want to know about generations of health, not just with that one individual. We want to know, was cancer in your family? Was it on your mother's side? Was it a maternal grandparent? And identify that cancer. We identify sickle cell. We identify all types of malady of diseases, correct? But then when we think about a social history of racism, then we want to say, oh, no. We've passed this. We've moved on. This isn't applicable to current day. So that's curious to me, right? So let's look at slavery, 1619, maybe even earlier, if you look, depending on the sources, right? So over 246 years of slavery. Then we have Jim Crow and Black codes and Reconstruction. We have the Civil Rights Movement. Think about this when you're talking about the body and health. You had legally sanctioned sexual and reproductive violence, right? You had lynching, which also often included sexual and reproductive mutilation. You have negative stereotypes, hypersexualized images of folks, no civil or human rights whatsoever for hundreds of years, right? And then limited civil rights. And so we wonder why we still wrestle with these vestiges of disparity, right? It didn't just poof appear out of a vacuum, right? Unethical and sexual and reproductive medical experimentation, laws prohibiting formal education in any way or limited education at some point. You had healthcare that was tied to a labor output. You have slave narratives talking about the fact that there was mass reproduction of bodies, and there was no, we get maternity leave, and now we understand the stress of the mother in the womb can affect the baby and all these kinds of things. Where was that thought during slavery, and how those things have been passed down generationally, right? Free labor and no income, racial and residential segregation, generational poverty upon generation. So think about how these things show up today when that patient appears in your operatory chair, right? It's not out of a vacuum. I want to look specifically at this concept of eugenics, right? And I think this is very important. This is the history buff and the ethicist in me kind of intertwining, right? Were you aware that over 33 states, as early as 1907, the US had instituted public policy that gave the government the right to sterilize what was defined as unwilling and unwitting people, right? Unwitting is not really a term we use today, but who do you think fell into that category, right? Of unwilling and unwitting people? Overwhelmingly, folks of color. So you had Black folks, you had Latino folks or Latinx folks, Hispanic folks. You also had poor white people, poor immigrants, or folks that were deemed on the lower end of the mental health spectrum. So folks that had maybe at that time some mental health challenges were also in this category. North Carolina, the state of North Carolina alone, sterilized over 7,600 individuals between the 1930s and the 1970s. Latino women in Puerto Rico, New York City, and California were specifically targeted by the government for sterilization throughout the 20th century. So we're not talking ancient history. We're also talking about folks whose children or grandchildren, or even depending on the age, they themselves could be in your operatory chair today. And so we're going to go into that a little bit later, but when we talk about medical mistrust and this mistrust of the healthcare industry, this is not outlandish flights of fancy, right? This is not fallacy that they've created. This is not fables and folktales. This is actually reality for them. Black women have also long been the targets of population control and been disproportionately affected by sterilization abuse. Instituting similar practices to those experienced in Puerto Rico, as many as 25% of Native American women between the age of 15 and 44 years old were sterilized by the 1970s. In the early 1970s, there was a specific incidence of 2 Cheyenne girls, so we're talking Native American girls in Montana, that entered an Indian Health Service hospital. They entered for appendectomies. This is documented in the 70s. Again, think about many of you were in practice in the 70s, right? Let alone the patients that we see today. These 2 girls on separate instances entered the hospital for appendectomies. While sedated, the physicians also sterilized the girls. No consent of the family, no discussion with the family. They sterilized these young girls when they were there for appendectomies. So this is not ancient history, particularly if you start looking into Native American history. And I was listening to a podcast a couple of weeks ago about the whole adoption project, where Native American young children were literally snatched from their families and given to white families to raise. It failed miserably in terms of the project. And I can't, her name escapes me right now. I have to look it up. But in Canada, there's a faculty member who is the only RN, PhD, and JD. So she's an attorney and a PhD, and she's Native American. And she talks about this project. She was actually the result. She was adopted. And she is a success story, but she talks about how that had such challenges for her along the way, right? So we have to remember all of our historic marginalized folks and how it's affected us. Even today, right? In 2013, the Center for Investigative Reporting, it came to light that dozens of female inmates in California had been illegally sterilized in recent years. And then even as recent as 2020, there were accusations of forced hysterectomies in ICE detention centers. So this is not ancient history. This is a recent history, if you even want to call that. So it begs to mind our morality, our ethics, our ability to make decisions as practitioners, the move away from paternalistic care, right? Where we're not just this authorities in white coats dictating what our patients should say yes or no to. And we may think, oh, well, we're not talking about feelings here, but aren't we? Why would it be different for life and death situations? We're still talking about irreversible procedures with what we do in the oral health cavity, correct? So we have to think about that. It's important for us to understand. Oral contraceptives, right? There were these trials in Puerto Rico. So if you are on birth control or any of your patient is on birth control, it's largely because of these uncontrolled trials that happened in Puerto Rico where there was experimentation without informed consent. I think lots of times when we talk about the lack of ethics in healthcare and medicine specifically, we immediately go to the Tuskegee experiment, which was catastrophic, right? But unfortunately, there are so many countless examples of where ethics did not lead us, right? So in this instance with Puerto Rican women, they were told that the pill prevented pregnancy, which we thought it did. We weren't maybe sure because it was a clinical trial, right? But they were never informed that this was a clinical trial. They were never informed of any potential side effects. So that is very, very important for us to understand. Now, when we talk about racism and medical mistrust, as we move from left to right on your screen, there's an excellent text by the name of Medical Apartheid. And you may think, apartheid? I mean, that's South Africa, that's such a strong term. But think about the definitions here again. So Harriet Washington is an ethicist and former investigative reporter and journalist. She details the dark history of medical experimentation on Black Americans from colonial times to the present. So again, not in a vacuum. This is what was once known as folklore, passed down from generation to generation, but now we are discovering evidence of these truths, right? Evidence that this is not just folklore. The most infamous example is really in obstetrics and gynecology, which centers the 2 photos at the center here, with Dr. J. Marion Sims. Most folks would know him as the father of gynecology and the father of obstetrics, but he had some very questionable medical practices. And I have this photo of the 3 women who now we have names for, Anarcha, Lucy, and Betsy, which we are now referring to as the mothers of modern gynecology because of Dr. Sims's really mutilation of their bodies with no anesthesia. He invented the sepulum and all kinds of things. And so it's important for us to understand that he acquired these slaves, many of them from childbirth. He put the slave women through painful surgeries without any anesthesia. He claimed that his procedures were not painful enough to justify the trouble and risk of attending the administration. But this claim rings hollow when we learn that Sims always administered anesthesia when he performed the actual surgeries on white women just a few years later. He cited the popular belief that Blacks did not feel pain in the same way as whites. Now, there are ways that those kind of misnomers and those kinds of falsehoods in history's old medical education still present themselves today, right? When we think about the prescription practices of providers, even in emergency rooms today, there is data and there is research that supports a huge bias where African Americans and persons of color, Latinx, Hispanics are not equally prescribed pain medication in the same way as whites would be prescribed pain medication rather, because of a misnomer that the pain threshold is different genetically somehow because of melanated skin, or that there's an assumption that there is drug abuse because of the melanated skin and the stigma and stereotypes and falsehoods around that, right? So that's important to understand. Then when we move to this picture all the way on the right, that is Iona State Hospital, which is in Iona, Michigan. And in the 60s, it was one of America's largest and most notorious state psychiatric hospitals before there was a move towards deinstitutionalization. Doctors at this hospital overwhelmingly diagnosed African-American men who had been arrested in protest, in civil rights protests, with schizophrenia because of their civil rights and militant ideas. This was the 60s. So again, these are folks that have had these experiences that could be our colleagues today or our patients today, or the parents and grandparents of our patients today. So this is readily in the conscious of patients that we encounter and see each and every day. So you may be familiar with the young lady all the way to our left. That is Henrietta Lacks, who is really famous at this point because of the HeLa cells, right? And any of you that have done work, and we continue to do scientific inquiry and research and discovery using the HeLa cells. She's actually a native of the state of Virginia, but was living in Maryland and underwent procedures at Johns Hopkins at the time due to cervical cancer. But her cells were found to be so effective in the study and scientific inquiry that her cells were mass produced. It actually just in the last couple of weeks, her family has actually brought a lawsuit, not against Hopkins, because Hopkins, whether it's accurate or not, maintains that they have never profited financially from the sale of her cells. But some of these biotechnology companies have, and now there are lawsuits pending from her family with these biotechnology companies. The next two photos you see here are the Organ Thieves book, which we're doing some work with here at the School of Dentistry, that talks about the shocking story of the first heart transplant in the segregated South, which happened right here at the Medical College of Virginia. This is a newspaper clipping from that time when the 53-year-old donor was identified. Bruce O. Tucker was a Black man who had fallen and hit his head and showed up, perhaps unconscious, to MCV. They did think they smelled alcohol on his breath, and so he was treated as a vagabond, as homeless, as no family, even though he had his brother's business card, who owned a store not too far from MCV. The brother's business card with the same last name which they wouldn't have known his last name necessarily, but he did have ID on him as well. There are made attempts to notify the family according to certain records and others not. But anyway, his heart was transplanted into that of a white male. The race is obviously significant there that time, that you took a Black heart and put it into a white person. But it's these truths and these stories and these narratives that, again, are not folklore, are not fallacies, but actually we're uncovering these truths. This is in the conscious, in the minds of some of our patients that we see today in terms of their distrust. You know, lots of people don't trust the dentist already because of anxiety or poor circumstances that they've had, outcomes where they've had dental appointments and the dentist wasn't the best dentist, right? But one of us has an impact on the entire profession. Those of us that engage in patient care can tell you litany of stories about how a patient shows up and says, oh, I hate you. And I'm like, okay, I'm Dr. Smith. It's nice to meet you for the first time in life ever. I'm not sure why you hate me, but what it is that one bad experience marred our profession for them. In the same way, how can our patients who have been generationally on the receiving end of these kinds of racist tactics and behavior not be viewing medicine and medical ingenuity and innovation in the same way? And we'll get to that. I always like to point out some positive, right? So this is Dr. George Simpkins, and this is where one of us actually can make a difference. He was a dentist, a local dentist in Greensboro, North Carolina in the 60s, and he brought the federal lawsuit against Moses H. Cone Hospital and Wesley Long Hospital that were white-only hospitals. He had a patient that had a severe dental abscess at the time that needed hospitalization. And he initially lost that lawsuit because the all-white jury found in favor of the hospital, but on appeal, he won. And what's important is that that lawsuit, Simpkins versus Moses H. Cone, set about the trajectory that desegregated Southern hospitals throughout the United States, right? So a dentist actually led that legislation. And so I think it's important as we talk about buzzwords like interprofessionalism, right? You guys take some courses, or we teach some courses where we talk about interprofessionalism. This is something that dentistry has been a part of for many, many decades and has had a role in playing in particularly underserved providers that are crossing disciplines and crossing boundaries. So I always like to offer that because I think it's a neat anecdote to really understand that one of us, sometimes these topics seem so mammoth, right? It seems like, how can we at all tackle racism in healthcare? How can we ever move the needle on healthcare disparities? But one of us, each of us can make a difference. I think it's also important, I've mentioned it a little bit, but to connect this to medical mistrust and even present day vaccine hesitancy, right? So this is an article that was written by an esteemed colleague, Dr. Reuben Warren, who is a noted Harvard-trained public health dentist and former dean of Meharry, who's now the director of bioethics at Tuskegee. But this talks about, particularly, it's a little dated from last year, but it talked about the lack of COVID vaccine trials within the Black community, right? And this medical mistrust and this hesitancy to participate in vaccine trials. There's a lot of work is happening even here with Dr. Nguyen and Massey Cancer Center here at VCU to talk about medical trials and medicine trials and how we need more participation from African Americans and Latinx and Hispanic and Native folks. But there's hesitancy around the issues because of the medical mistrust. And what I want to point out is that this is not a rumored medical mistrust, or this is not medical mistrust that's simply in the psyche of our patients, right? This is actually a medical mistrust and distrust that was well-earned. And I think it's important that we point that out. Like, the distrust they have is well-earned, but how do we combat it, right? How do we speak about it today? How do we understand it in terms of how we move forward? This is a quote that I like to bring up because I think that so often we try to skate around race and racism, and I don't think we will ever move the needle forward on health disparities, health inequities, a more diverse and inclusive profession, if we can't actually call a spade, as it were, to use a colloquialism there, right? To actually call things on the carpet as they were. And so this is from Du Bois, W.E.B. Du Bois. If you're not familiar with him, you should certainly read many of his works, an eminent scholar of the early 1900s and late 1800s. He says that the problem of the 20th century is the problem of the color line. The question as to how far differences of race, which show themselves chiefly in the color of the skin and the texture of the hair, will hereafter be made the basis of denying to over half the world the right of sharing to utmost ability, the opportunities and privileges of modern civilization. So translate that into today. He had his finger on the pulse of something in 1900 that still confounds us today, is that race and racism are part and parcel and perhaps the chief determinant of who has access to healthcare in our nation, and even globally. I have a colleague at Meharry, Dr. Eleanor Fleming, who spoke for our Phillips Institute group, I think a month or two ago, but she's coined a fascinating point of inquiry and a question, I think, for those of us who do research particularly. She wants us to stop talking about race and really focus on talking about racism. So as you fill out a survey or construct a survey, or you think about a clinical trial or whatever you're looking, we often have demographic questions, right? That will say, fill in race, fill in ethnicity. And her point of inquiry is saying, no, that's good, but does it actually help us eliminate health disparities, or does it confound them and exacerbate them, because we're not actually getting to the issue at hand, which is racism and the differential or preferential treatment that may or may not happen as a result of someone's race. So let's bring that home in real tax, right? What does that mean for you as a private practice doc? What does that mean for us in dentistry as we create surveys and do clinical research? Perhaps the question we need to add to our health history, just as we have educated ourselves and become more aware that we need to ask questions around gender identity, right? And we ask for folks' pronouns, right, on medical history forms. Perhaps we need to be asking, in the last 6 to 12 months, have you experienced perceived preferential treatment based on your race? Is that a question we need to be asking? Because does that inform us of some experiences or some inequities or some health malignment or even distrust of medical systems that the patient may have as a result of asking that question? So does racism actually impact oral health? And we're winding up here, but I want to get to this, right? And so you may be saying, this is great, Dr. Smith, this is great, Carlos, and it's an overarching, but how does this relate to dentistry or oral health? Well, one, I think we have to talk about oral health because I was in a lecture not too long ago with a very good mentor and colleague, Dr. Leo Rouse, who's outgoing president of American College of Dentists and Dean Emeritus at Howard. And he said, you know, we as dentists do not have a copyright on oral health. Perhaps we think we have a copyright on dentistry, but we do not have a copyright on oral health. And if we don't really pay attention, all of our collaborative partners, whether that's nurse practitioners, whether dental therapists, whoever it's going to be, is looking into how to advance oral health. And so the question about racism in oral health is very fundamental. These are some colleagues from Australia that are really forward thinking. They've done a lot of study around Aboriginal healthcare, Native folks of color in Australia, right? And so does it impact oral health? The overwhelming answer is yes. Through the creation of inequitable access to oral health services, right? Or the receipt of lower quality care, through psychological and physiological outcomes of those discriminated against that directly impacts oral health. For example, their experiences of racism causing psychological stress, right? So that's maybe why that question needs to be added to our health histories, which impacts on oral health behaviors and ultimately clinical oral health outcomes through the undermining of dental health service provider-patient relationships, right? This is also a study that's important. So racial discrimination and uptake of dental services among American adults. So the effects of any particular form of racism on oral health haven't been studied robustly. But what these colleagues have found is that individuals who reported the emotional impact of discrimination, so I'll say that again to slow it down. Individuals who reported the emotional impact of discrimination rather than the act of discrimination itself were less likely to utilize dental care services in the last 12 months. So basically, this study found that for those individuals who said they have been psychologically impacted by racism, whether that be stress, fatigue, a number of different ways that they could be psychologically impacted by racism, right, are less likely to utilize dental services. Racism in oral healthcare delivery of services and its effects right there. Now, structural racism and oral health inequities, right, by a colleague of mine by the name of Patrick Smith, who's a good friend of mine and a colleague at the University of Illinois, Chicago. Examples of intrapersonal racism that impact on oral health include community acceptance of poor oral health. So for some communities culturally, oral health is just accepted. We see that even in rural populations when we're not talking about the racial issue, right? Or a question of race or racism, that some rural communities that were, farmer towns or migrant towns or towns where, 50 years ago, everyone worked for a factory, but now you would never put a town there, right? They're still wrestling with the fact that great granny's teeth all came out, grandma's teeth all came out, my teeth all came out. So surely for my child, all their teeth will come out. And the plight of life is that you have dentures, right? So community acceptance of poor oral health, personal feelings about shame, guilt, or lack of confidence because of poor oral health. I think we're even seeing that with the present day use of Zoom and how many people have Zoom meetings, how people are seeing your smile, right? So shame or guilt there and lack of confidence in getting oral health care, and then low self-efficacy and sense of fatalism. So that means poor oral health being used to consider a norm or not. So we see that in structural racism as well. So what do we know about access to care? And so I think this is important for us to understand as well in terms of access to care. What we know quite clearly is that non-white providers are more likely to serve uninsured patients and practice in underserved areas. This is not anecdotal. This is the data. This is from 2017 from the Journal of Public Health Dentistry, right? And so this particular graphic is about our Hispanic and Latinx colleagues, right? 44% of those clinically active Hispanic or Latinx dentists report that they primarily treat underserved patients at their primary practice. Almost 3/4 of those Hispanic or Latinx dentists reported discounting or waiving fees for patients who are either uninsured or unable to pay. So what's important in the takeaway is that Hispanic and Latinx dentists report a wide range of patient population characteristics, but are clearly an important access point for minority and publicly insured populations. We see it overwhelmingly as well with African-American or Black populations, right? Again, non-white providers are more likely to serve uninsured and practice in underserved areas. Here we had 53% of Black clinically active dentists reported that they primarily treat underserved patients as their primary practice. 30% of those reported public insurance programs covered a majority of their patients. So public insurance programs like participating in Medicaid, right? Versus when you compare the ADA survey of dental practice, only 6%. So 30% versus 6%. So that's a big difference, right? So most Black dentists, it says almost 70% reported discounting or waiving fees for patients who are either uninsured or unable to pay for an average self-reported value of over $54,000. So that's not to say that white dentists don't also discount or waive fees. They do. But it's saying that overwhelmingly the patient profile of Black dentists indicates that they are a critical access point for minority and low-income populations to gain dental care. So this is important for access to care. This is important as we talk about admissions programs and protocols and policies and demographics of dental classes, of residency classes, of grant dollars for programs that help prepare perhaps those students that otherwise are battling some things to have access to enter into the dental point as a career. It's also important that we understand how implicit bias works when we talk about racism and how it shows up and presents today, right? So we all have blind spots. We all have implicit biases at work, not just white people. And I want that to be very clear, right? It's not a guilt or a shaming. We all have them. The great thing about implicit bias is that it's malleable. We can teach to it, we can alter it, we can change it. And so basically implicit bias is everyday cognitive processes of how we process information, favorable or unfavorable. It's activated without awareness or intentional control. It develops across our lifespan from lived experiences, but also how we've been socialized. And so perhaps stereotypes we've been raised around. The important thing is that if you can check your bias and still be fair in your treatment of others, that's positive. Well, what often may happen is that the implicit bias affects our behavior, resulting in discrimination or differential or preferential treatment for certain groups of folks. It can be internalized, and those being subjected to it, there's evidence of poor psychological and physical health around that. But it's malleable again, so it's important. I like this graphic because for those of you that are practice owners or something like that, think about your hiring process. This is, as much as I hate to admit it, this is a study from Ohio State. Most people know I'm a Michigan grad, but they have a Kirwan Institute about race that has some great information. And if you're interested in more of what I'm talking about, I would encourage you to look there. But they talk about how implicit bias affects employment decisions. So look at the intended process, right? We want to recruit a diverse range of candidates. We want to interview and select the top talent. We want to promote based on performance review alone. That's what we say. That's what we intend. But that's actually not what happens. The evidence shows us that the actual process is implicit bias rears its head and impacts where and how we recruit. So if we're talking about example for employment, where do you recruit your hygienist? Where do you recruit your dental assistant? Where do you recruit your dental associate? Say you're looking to hire a new associate. Do you only recruit at your local VDA meeting? Do you only recruit from friends and family? Do you only recruit from your country club membership? Do you only recruit from whatever other fill in the blank membership that you're a part of, right? It's not to say that you can't recruit from those areas or that it's not normative to recruit from those areas. But I want to be clear that if we say that diversity, equity, and inclusion matter, and we say we want to cast a wide net and have a diverse pool of candidates for whatever the fill in the blank thing is, then we have to actually look at our behavior and our patterns and where that comes from and why. We have to have an emotional intelligence about why we think and do the things we do and feel the way we feel, right? So implicit bias impacts that. So where that recruitment takes place. So then, of course, that's going to skew the process. So that's going to skew the pool of candidates that we have, right? The same thing for dental admissions, the same thing for whatever. That's why we have recruitment programs that may be targeted towards historically Black colleges and universities, like where I went to undergraduate, like Hampton University, right? So it doesn't mean that there are any less of standards. It doesn't mean that the admission standards are any different. And so I think that's very important to point out that oftentimes when I'm talking about diversity, people immediately go to competence. And so that should raise questions and red flags in your head right there, because we're talking about diversity and inclusion. No one said that there was a lack of competence, right? No one said that there was a lack of skills. No one said that there was a lack of intelligence. So that's important for us to know and recognize those biases. So then, of course, it affects who you end up hiring in this instance. So I hope that's helpful for folks to think about. It also shows up in our patient case, right? And so I show this slide to our prospective admissions candidates, and I'm going to talk about what happened just on Friday when I talked about this with our admission, that cadre of admission candidates. But this was a study done in 2019. So this is not 20 years old, right? 2019, where a clinical example, a clinical scenario where the patient, identical patients except race. One patient was Black and one patient was white, but they needed, they had irreversible pulpitis. For those who are not clinicians, that's an infection or inflammation of the pulp, the nerve of the tooth. And there are two ways to deal with that. You got to get rid of the nerve or get rid of the tooth. You get rid of the nerve through a procedure called a root canal, or you get rid of the tooth through an extraction, right? You pull the tooth. So overwhelmingly, with this group of dentists that filled out this survey and this instrument and participate in this study, same patient scenario, same examples, same clinical photos, same radiographs, same diagnostic information. One patient white, one patient Black. The white patient was overwhelmingly recommended to get the root canal, and the Black patient was overwhelmingly recommended to have the extraction. Why? This is implicit bias at work. This is the vestiges of racism in our healthcare, in our society, and in our healthcare systems and our institutions at work. I pose this question to prospective students on Friday, and it's usually rhetorical, just like I asked you guys why, right? And someone shouted out, it's what they can afford. I was a little disappointed, but I appreciated his honesty, right? And I was able to say, okay, say more about that. So you said what they can afford. So you're assuming Black people cannot afford the root canal and white people can, right? So now we're drawing income, wage earnings, tax brackets, socioeconomic status explicitly apply to race, and that's not true, right? Because just like you have rich and poor of all demographics, right? You have rich and poor Caucasian folks, you have rich and poor Black folks, you have rich and poor queer identifying folks, you have rich and poor of every category. Not to mention that even if someone is categorized as poor or income contingent or lower wage earning, folks make priorities. And what I explain to our students here when I teach ethics to our second year students, what I explained to this scenario to those prospective applicants is that you may have a patient who is poor by your standard, but they have priorities. And if they decide that their teeth are a priority, they'll find the money or be able to save the money to get that crown, to get that root canal. You can't make that decision for them based on presumed level of interest or income. And in the same way, you have someone who could afford all kinds of dental treatment who will choose to get their tooth pulled, right? So we have to be aware of those biases and begin to combat them. It's important to understand microaggressions as well, right? And so a microaggression is an everyday, subtle, intentional, sometimes unintentional, sometimes intentional way of behavior that when you have two different groups, you're basically saying that a dominant culture is normal and the other is not. So in the United States, of course, the dominant culture is white and everything else is other. And so sometimes, even though I'm the DEI guy and I do DEI work, I'm limited, and I don't even like sometimes the word diversity because of how it centers whiteness. And I don't mean any guilt ascribed to that, but we're centering whiteness and everything else is other. That's problematic in and of itself, right? And just the language that we use to convey these topics and principles. So when we talk about microaggressions, these are these subtle everyday jabs, right? It's not super important for the purposes of this presentation that you are able to define or delineate micro insult, micro invalidation, but let's look at an example. A Latina administrator is described as spicy, right? What does that mean? What are we getting at? So culturally and sexually objectifying her, diminishing her leadership skills, her effectiveness as an administrator. A Black male college student at a highly selective university, right? Let's go with the University of Michigan. No, I'm kidding. Let's go with Harvard. Is asked what sport he plays, right? Because it is presumed you couldn't possibly be here without needing to be an athlete, right? So there's an underlying assumption that he did not gain admission based on his academic credentials, but rather his athletic ability. So I'll give you one that I get all the time. And I understand that communication is a strength of mine. And I appreciate that people share that with me. And I like that people share that with me. But I'll get, sometimes people are shocked, like, oh my gosh, you're so articulate. You're so well-spoken. Well, I have lots of degrees, post-secondary degrees. And so if I can't string a couple of verbs together, then we have a problem, right? And so I understand everyone's not good at public speaking. So sometimes it is a genuine compliment, but sometimes there's something underlying, something underneath it that's jabbing, right? And so what do we do with that? Why is this important? Because what are the effects of microaggressions? There's a colleague, an emergency room physician, attending physician, Black female, who's been at Emory in their emergency room for many years. In the Wall Street Journal and New York Times did an article with her a couple of years ago, and she talked about microaggressions being a death by 1,000 paper cuts. And that's never left me because it's these little everyday jabs that then begin to have these kinds of effects on the person that is on the receiving end. Anger, frustration, exhaustion, diminished self-confidence, poor self-image, depression, anxiety, trauma, how it shows up, right? And so this is really important because it ties in another scholarly area that I'm really fascinated with, which is resilience and well-being. And so if you look at the center, the patient well-being is our goal, right? Well, what's feeding into that? The clinician-patient relationship, and then what feeds into that? Clinician well-being. So how healthy you are as a clinician is going to affect the ultimate outcome of our patient well-being. And what affects us in terms of the health of us as the care provider? Society and culture, personal factors, skills and abilities, healthcare responsibilities, learning practice environment, organizational factors, rules and regulations. So we don't show up to work in a vacuum. And this is not just specific to persons of color. No one shows up to work as a vacuum. This framework is for everyone, irrespective of race. But our experiences, our lived experiences, whether that is around gender and gender identity, whether that is around sexuality, and sexual orientation, whether that is around race and ethnicity, we have different lived experiences and we show up in the workplace differently. And we have to account for how that can affect someone, how can it make them feel, how the day that can have, and then how it affects the patient. For a quick example, look at this next slide. How does this affect everyone? Differently. We can agree on the left that we all were affected by COVID-19. We're still in it, actually, to be truthful, right? It's not gone, it's not gone away. But then you had the Black Lives Matter protests. And then we start to divide maybe on our feelings about that. And then you had the events that happened or that we're now told maybe didn't happen, but that many of us saw happen on January 6th, right? And how that affects us and our psyche and how we show up to work, and then ultimately affecting patient well-being and outcomes. So this is not in a vacuum for your colleagues, for your students, for folks that you interact with. Particularly, let's take me as a Black male. The day after the George Floyd incident, when that came mass, and I've never even watched the video, it's too traumatic for me, I can't watch it, right? But after that news spread of his murder on the ground, and we don't have to get into the trial and all those things, but think about how that then affects me and how I show up to work the next day, right? It doesn't necessarily affect you the same way, but how it affects me. And so think of all the different things. Think about the things that were happening last summer with all the Asian hate, right? And the issue in Atlanta where all the Asian folks were kind of killed at that salon at one time. How does our Asian student, colleague, staff member show up into work, into your practice the next day? We have to begin to talk about wellness and how that relates to how we see differently in the racism that happens in our nation. And real quickly, I'm at time, but I just want to get through this real quick. It's important to think about our identity. This is a tool that you can use, and I'll see if we can, I'll put our slides in a PDF format and send those out to everyone. But it talks about the social identity matrix and where we show up and how we identify and what is considered normative and what's not and why, right? And just briefly, I do want to have a positive aspect to this in terms of mitigating bias and introduce you to something called the pause method, right? So pause, the acronym, and you can look this up and find it. It's common, not common knowledge, but it's commonly out there. Pause, pay attention to what's happening beneath the judgments, right? So A, acknowledge your own reactions, interpretations, and judgments. You understand the other possible reactions, interpretations, and judgments that may be possible. S, search for the most constructive, empowering, or productive way to deal with the situation. And E, execute your action plan. Act consistently with what makes the most sense. So you've got to have some action. And pretty soon here at the School of Dentistry, really across the health science campuses, we're doing something called stepping in training, which is going to specifically work with our faculty and folks who are clinical facing around how to step in around issues of bias and racism. So look out for that. And so just real to wrap things up, I know this was a lot of information I threw at you, right? And I'm talking a mile a minute. But what does this mean for us? I'm just a positive type of person. I'm a glass half full kind of guy. And difficult roads, though they may be, lead to beautiful destinations. So we really can get to optimal oral health care for all, but we have to chart through this muddy territory, right? This muddy water. And I also think it's important to point out that often we'll talk about the golden rule, right? We'll talk about the golden rule, and we'll talk about the fact that we should treat others how we want to be treated. But I want us to think about something a little bit different. How about treat others how they want to be treated? Because we all come from different cultural backgrounds. We all have different things that are normative. We all have different belief systems and understandings. So it's important that we actually tap in and make inquiry of the other to say, how would you like to be treated? And that is where we should land. And that is where we should be. We're at time, but I will take a couple of questions if folks have questions at all that you can put in the Q&A or put in the chat, and I'd be happy to take maybe 5 minutes of questions if folks want to stay with us on that. Any questions at all? Lots of thank yous. I really appreciate that. Yes. Is there a way to get a copy of the slides or a copy of the recording. We will have a copy of the recording. We post them to YouTube. So probably at the end, probably next week, we'll post a copy of the recording of each day's events this week, except for our last day. Our speakers asked not to record that on the very last day. So pay attention to that live. But yeah, we'll put the recording up, and I'll have our CE office and everyone email out the PDF of the slides. I don't have a problem with that yet. But thank you guys so much for attending. We had a robust, we have one question. Can I comment on the notion of belonging, right? So yeah, sure, I can comment about belonging. So even in some systems and organizational hierarchies, folks are talking about DEI-B, and some folks even add a J for justice, and the B is belonging. Belonging is where we go from inclusion with everyone feeling included, right, and having a voice, to now we create an environment where everyone actually feels like they can belong. You'll see a lot out today about folks can show up and be their full self at work, but that requires a lot. There's this notion of identity covering where, say, for example, you have a colleague who is identifies as queer, but maybe they're not out. And so a simple question like, oh, how was your weekend? Or what'd you do this weekend? May put them a little skittish because maybe they did something that if they told you what they did, if they went to this pride parade or something like that, it would out them and they don't want to be outed, right? So that's called identity covering, where they kind of pivot and maybe say something else that doesn't actually allow them to unfold who they are. I think about the history of passing, right? Very, very fair complected African-Americans who passed for white really is born out of this notion of identity covering. And so that's just an example of things and practices that people from historically marginalized communities often do, even without understanding, so that they feel like they belong in a space. And so I think there's a lot we can do around bias to mitigate bias and counteract bias to get to this sense where people really do feel like they belong. It's along the gender spectrum around belonging and feeling actually included. There's tons of research out there, particularly in male-dominated fields, where you may have one woman represented on this board, one woman represented in this senior leadership. And so she doesn't really feel like she belongs because she's ostracized, or she tries to speak up and then she's belittled or she's not heard. And Johnny says the same thing. And it's like, oh, pat Johnny on the back. Well, Susan just said this and no one heard her, right? And then eventually Susan retreats, right? And so then Susan doesn't want to meet you at the water cooler. Susan doesn't want to chat at happy hour. Susan doesn't want to attend the Christmas potluck because she doesn't feel like she belongs. And so it's cyclical in that way. So that's one of the things we have to really get to. I think that it requires some steps, and it requires leadership that's really willing to tackle these kinds of issues head on. But I think that's where ultimately we want to go, is that everyone, despite the isms, despite and including and valuing all of your identities and the ways those different identities intersect, that folks can belong in a space. Yeah. I can maybe take one other question and then we'll go from there. I really thank so many people for attending. It seems like so many people are still logged on. Again, please attend the other sessions this week. We have a great session tomorrow about trauma-informed care with a clinical social worker who's really going to be talking about how to best provide trauma-informed care to our LGBT plus populations and patients and even colleagues, all right? So everyone have a great day, be productive, make it a great one. Appreciate your attendance. Have a great afternoon.